Hello, Arti. Are you there?
Yes, Himanshi, I'm here. I'm here. Can you hear me, sir?
Yeah.
Okay. So you can share your screen, sir. Yeah, you can share your screen.
I know. Good evening, students. We will continue with the. Am I audible?
Yes, sir, you're audible. But make sure you have shared your screen because I cannot see your shared.
No, I have not shared the screen.
Okay, okay, okay. You're audible and visible properly, sir.
Okay. Is my screen visible now?
No, it's not visible. You need to share your screen. You need to click
Okay,
on a
let me
share
do
screen
it.
button. Yeah. Yeah, okay, the screen is visible now.
Okay, is my screen visible?
Sir, the screen is visible, but I think you need to reshare your screen because the PPT which you opened right now is not visible. Actually, you need to first open your PPT and then you need to share your screen.
Okay.
You can just simply stop your screen sharing and again start your screen sharing with this PPT.
Okay, we'll do that.
Can I help, sir?
Uh,
Okay, yeah. Okay, yeah, visible. Just put it in a slideshow mode and then it is perfect.
okay, is it visible now?
Yeah, perfect, sir. Perfect. Thank you very much.
Okay, last class we came up to the electrocardiogram and we have to recapitulate. We'll just start with the electrocardiogram. And this I think in last class the case was being discussed by Dr. Said, or was he discussing the case? Anybody who would like to continue the discussion? Because the last class we didn't complete the discussion. We just discussed up to the electrocardiogram, and then we will have to proceed further. And what was the clinical diagnosis? Anybody who is in the group who was present yesterday or the last class can come forward and tell the level at which we have come to the discussion, and then subsequently we see the ECG, X-ray, and then echocardiogram. Anybody? Anybody who would like to take up the discussion? Somebody who is from Trichy, I think one was a third year DM student from Trichy Government Medical College, was discussing this. I think his name was Said. Is Egnath, is he there? Egnath, are you there? Anybody from the Dheeraj, would you like to discuss the case? Yogesh, would you like to discuss? Anybody who would like to volunteer? Eknath, you are there. Why can't you discuss the rest of the case?
Good evening, sir. Sir, myself, Dr. Karun from KPV, sir. Actually, Dr. Saeed is on duty today, sir.
Oh, I see. Are you from the same institution?
Yes, sir, myself. Same.
What is your name?
Dr. Karun, sir.
Dr. Karun.
Karun Khanna, yes.
Karun, oh, okay, fine, great. So I think, were you there during the last discussion last week?
Yes, sir.
Oh, so then you must be able to continue with that. To recapitulate, we looked at the clinical findings and what was our provisional diagnosis?
We went with transposition of
We thought of transposition of great arteries, yes. What else?
We had possibility of transposition of great vessels and VST with PS to is also there.
No, PS we didn't discuss because the patient did not have a very loud
Yes,
murmur.
yes,
Was only a very 2/6 murmur. So we didn't pulmonary stenosis. We
thought of transposition.
Because of the cyanosis starting from day one, we thought of the possibility of either transposition physiology or we thought of the possibility of admixture lesion.
Admixture, yes.
So, but then the patient has undergone two interventions, which we thought was septoscopy, and so we thought of the possibility of transposition of great arteries. He gave a history of suggestive of a high flow group, since we thought that there may not be any significant pulmonary stenosis. So those were the important salient points, which was actually supported by clinical examination, where there was no significant murmurs. Practically excluding the possibility that there may not be any significant pulmonary stenosis. But oddity was that he was 22 years old, and usually the life expectancy beyond the second decade is in the third decade actually occurs only in patients who have got a VST-PS physiology. So we had a bit of a confusion whether why the patient has got a long survival. Because of the lack of significant murmurs, we thought of the possibility that we have to entertain still a case of transposition of great arteries. No PS, and there must be VST and as well as a ASD, and also probably the patient's ASD has been dilated, or rather it has been made bigger by a septostomy procedure, and hence our provisional diagnosis would be cyanotic congenital heart disease, transposition of great arteries, septostomy procedure, high flow group. Then he had a recurrent episodes of heart failure, and he had brain abscess. So all put together, this would be our provisional diagnosis. Now we'll start with the electrocardiogram, which we have partly interpreted. So what is the electrocardiogram showing? Is it supporting our diagnosis, or you think that this does not support? Karan?
Supports are diagnostic. There is otherwise I call it and
speak loud so
there
that
is extreme active.
Speak loud so that you are audible to everybody.
Yes, citus solid. This ECG with the normal standardization and normal paper speed shows citus solidus and citus solidus with
Why did you
Sir,
say the situs?
there is extreme axis.
Why did you say the situs solidus?
So P waves are still there is the P wave positive in one, and sir, there is uh, the so basically
By looking at the electrocardiogram, how did you say that it is situs solidus?
the P waves we have to see that in
Okay.
that,
PVA appears as though it is coming from a normal sinus
normal
node and is spreading
and
in the
pos
normal
spread.
direction because
Yes,
of the P in B lead one is positive. There is a
one positive and AVR.
that it is a P is coming from the normal side and is spreading normally. But how are you sure that this is situs solidus?
Sir,
Any one of you? Can you comment about the the situs by looking at the electrocardiogram? No, it may not be always possible because see here you are there is still a possibility that in some of the complex congenital heart disease you may have a situation where there is a patient may be having a levocardia and it may be having situs inversus. So don't make a commitment which you cannot actually support. You
okay.
just say that there is a sinus rhythm and the P is coming from the usual site and is spreading in the correct direction. So you can say that right atrium is on the right side and the left atrium is on the left side. That you can say. Okay, right. Yes, go ahead.
Then, sir, there is normal PR interval, and both seems, sir, there is big P waves in lead 2, and there is later part of P wave is enlarged in V1. Seems like there is biatrial enlargement.
Okay. Definitely, the
And
bilateral enlargement. There was a discussion last class where the P, the negative portion of the P, has got a rapid downstroke, and that may be a point for you to suspect that this could be only right atrial enlargement. But then you expect some degree of initial positivity in the right atrial enlargement, which is not seen. So I think it is correct to interpret that the patient is having right atrial as well as left atrial enlargement. Okay, right? Yes.
there is sir, the axis is extreme axis.
Yeah,
Uh,
it's in the right upper quadrant. And what is the loop like? Is it a
counterclockwise loop.
or a anti-clockwise or a counterclockwise loop?
Counterclockwise loop.
Yeah. Why did you say it's counterclockwise loop?
So there will be negative RH will be seen in inferior lead, and there will be the AVR is positive.
Yeah.
Extreme is there. So
There's a
the
small, there's a
direction of
small Q.
depolarization.
There's a small Q in lead one and AVL with a very with the negative lead or negative, mostly negative complexes in inferior leads with a positive complex in AVR. It usually shows that the axis is counterclockwise. Okay, so I think it's counterclockwise loop. What are the conditions in which you can get counterclockwise loop?
Ostium primum AST can have counterclockwise.
Okay, but they can have left axis deviation, need not always have counterclockwise. It is usually associated with complex congenital anomalies like transposed to great arteries, double outer right ventricle. So these are the situations where you can actually get a counterclockwise loop, and that will help you in the diagnosis. Okay, right. Go ahead.
There is sir, RBB seen in RBB right bundle branch block is there.
Is that RBB or RSR dash pattern?
RSR.
So for RBP, the patient is having an RSR pattern, and what is the duration of the QRS complex?
It is around 80 milliseconds.
Yeah, it is around 80 or less than 100 milliseconds. So it is less than 12 divisions, maybe two divisions or two divisions plus. So it's 80 plus. So that does not qualify for
complete RB.
a complete right bundle branch block. It is incomplete right bundle branch block or is an RSR pattern. So in RSR pattern, how will you assess the how will you decide about the right ventricular hypertrophy?
Sir, in incomplete right bundle branch block, the R is more than 10 mm, and in complete right bundle branch block, it is more than 15 mm. You
In
say RB.
RSR pattern, if the initial R is more than 7 is enough. 8 or more is abnormal. And if the RSR in the R wave, if it is equal to or more than 15 millimeters, that also qualifies for right ventricular enlargement hypertrophy. Usually, RSR pattern is a feature of right ventricular volume overload more than pressure overload. But there is a hypertrophy because of the volume overload. Okay, yes, go ahead. There's a transition from V1 to V2. What does that mean?
Sir, septal.
Any one of you, anybody who would like to give a comment why there's a transition from V1 to V2?
Non-restrictive VSD.
Yeah, usually it is an evidence for a non-restrictive large VSD. Okay, anything else? Is there an LVH in this patient? By voltage criteria, it does not satisfy LVH, but there are good forces in the V5 and V6. LV forces that may make you suspect that probably because there is an RSR pattern in V1 and there is prominent significant R waves in V5 and V6. The voltage criteria is not satisfied, but I think that gives us thinking that probably the patient may be having biventricular enlargement. Okay, what do you expect in the X-ray chest? Parent, what do you expect in the
Real appearance for TGA is agon side appearance if it is TGA.
Usually agon appearance side appearance mostly you see in children, but in adults sometimes it may be difficult to get that picture. Okay, so anybody who would like to comment about the X-ray, is it suggestive of transposition or it is unusual for transposition? Any one of you? Saroj, would you like to give a comment? Your voice is breaking. Hello. The question is, does this X-ray suggest that this could be a transposition or is it odd? Anybody would like to give a comment? What is the classical feature of a transposition X-ray? What is the relationship between the aorta and the pulmonary artery in transposition? Anteroposterior, is it lateral? What is the relationship between the aorta and the pulmonary artery in transposition?
Aorta is anterior and left to pulmonary artery.
Yeah, pulmonary artery is posterior and aorta is anterior. So what will happen to the pedicle?
The pedicle becomes small.
Yeah, pedicle becomes narrow. That is the issue. Here, what is happening to the pedicle? Is it narrow or is it broad?
The pedicle is somewhat broad, sir.
It's somewhat broad. It is not narrow. So I think from the X-ray chest, you cannot make a diagnosis that this could be a transposition. And also, we had thought of an increased pulmonary blood flow What do you think about the pulmonary blood flow? Do you think that this could be part of the pulmonary artery? And
Yes,
do you
sir.
think that
Pulmonary aortopulmonary window is slightly enlarged, sir.
well, what do you think about the right pulmonary artery? Is it enlarged, or what do you think? Is there evidence of pH, or is it a reduced pulmonary blood flow?
So pulmonary, right descending pulmonary artery, sir, seems to be enlarged, but beyond that, I am not able to see. Sir.
Very good. So the right pulmonary artery seems to be larger than expected, but as you go to periphery, there is no more shadows are seen. So that may indicate that patient might have had a pulmonary arterial hypertension. So
Hello,
that
sir.
yes.
Sir, yes, sir. There was a problem in my audio, sir.
Oh,
Yes.
is it better now?
Yes, sir. I can. Yeah, sir.
Okay.
Yeah. Sorry,
So, would you like to comment about the X-ray of this patient?
sir. So this X-ray chest PA view, it is showing, sir, there is no cardiomegaly.
Yes.
And sir, the apex, sir, to comment on the apex, sir, it is difficult to comment, sir.
No. See, when you want to comment, what do you think is looking at the apex? Do you think it's more like RV type or more like LV type?
Sir, LV type.
LV type. I think from the X-ray wise, it looks more like LV type.
LV type. Yes, sir.
What are the cyanotic congenital heart disease which can be associated with LV type?
Tricuspid atresia.
Very good.
Sir, the transposition of great arteries.
Huh? Why should transposition of great artery give rise to LV apex?
Sorry, sir. No, sir. Sorry.
Because
Sorry, sir. No, sir.
Arising from the
No, sir. I am wrong, sir. Not transposition, sir. Endocardial cushion defect. With significant mitral regurgitation.
MR is significant. If
Yes,
there is
sir.
significant MR, sometimes you can have an LV apex. Okay.
And sir, single ventricle physiology can have.
Yes, very good. Single ventricle, about 80% of them are LV single ventricle, and then we can have LV apex. Very good. What else? Any one of you?
Abstinence can have LV apex.
Which one? Which one?
Abstinence.
No.
Normally,
Usually, it is very difficult to. First of all, difficult to palpate the apex, and X-ray chest will not have any evidence to suggest that this is an LV apex. It is not an in abstinence. You cannot have any. You don't get LV apex.
Fallot's tetralogy with significant aortic regurgitation.
Very good. In older people with tetralogy of Fallot with significant aortic regurgitation, they
Or
can
collaterals, they are significant collaterals as well.
patients with significant collaterals or a large man-made shunt, they can all have apex like a central shunt. Very good.
DOR with restricted VSD, sir.
Very good. DOR with restricted VSD. One more condition.
Top with AR.
That was already, that has been mentioned. One more condition.
Dextrocardia with normal cycles.
Not dextrocardia. We have already mentioned the 5 conditions. There is one more.
Truncus will be there.
Very good. Truncus arteriosus usually is associated with fungal regurgitation, and they can have a LV apex. So these are the 6 conditions where there can be LV apex can be associated with cyanotic congenital heart disease. So to repeat, one of you, can you repeat what are the conditions where you can get LV apex associated with cyanotic congenital heart disease?
Sir, BS, this DRV with VSD, sir. Restrictive VSD.
No, you cannot say DRV with VSD. You should say DRV with restrictive VSD.
Restrictive VSD, sir.
Yes,
Then, sir, truncus is one. Sir, then, TUF this TUF with AR, sir.
Okay.
Then, sir, ostium this
AV canal defect with significant canal defect with significant mitral regurgitation. Okay, yes. What else?
Single ventricle, sir.
Single ventricle. And the most of the commonest and the most important you are not so far mentioned.
And tricuspid atresia.
This here. See? Tricuspid atresia or tetralogy of Fallot in patients with a man-made shunt or a large aortopulmonary collaterals, which can give rise to large volume overload of the aorta, a large overload of the left ventricle, and that can give rise to sometimes LV apex. So these are the conditions where there can be cyanosis of LV apex. Okay. Does this X-ray suggest to you that this could be transposed to great arteries? What do you think these shadows seen side by side? Is it large aorta?
Yes, sir. Looks like aortic. Like it is. We should not say unfolding, but sir, arch of aorta is very much enlarged. Side by side is possible, sir.
It is. It seems that there is a large vessel. It seems more like an aorta. And pulmonary artery is not clearly seen at all. I cannot see the main pulmonary artery here.
Maybe anteroposterior. Yes.
And right pulmonary artery is seen. So X-ray is not giving us any clue regarding the diagnosis. If at all, it is X-ray is not suggestive of transposed to great arteries.
But plethora is present.
Beg your pardon?
The plethora.
Plethora, I am not certain about the plethora because it's not an ideal X-ray to because it's slightly overpenetrated. But I can definitely see a large pulmonary artery on the right side and peripheral cutoff indicating that it's pulmonary artery hypertension. For me to say that there is a definite plethora, I must be able to see some end-on vessels which I am not able to see. So, if I am asked to comment, I will say that I am not able to see end-on vessels, but definitely there is a large right pulmonary artery, peripheral cutoff. And one of the reasons for a large peripheral pulmonary artery with peripheral cutoff could be an increased pulmonary blood flow, which has resulted in Eisenmenger reaction and peripheral pulmonary vessels have been cut off. So, but I am not able to make a comment that there is definite evidence of increased pulmonary blood flow since I am not able to see any end-on vessels.
Good evening, sir.
Good evening.
So is there calcification there on right side or calcification you can?
Right side or left side, you mean?
Both.
You are saying?
Right side also, sir. Right side is also calcified.
No. What can be this? Can there be a calcification? And if there's a calcification, what can be the site of the calcification? What are the calcification of vessels that you can see in a cyanotic congenital heart disease patient or cyanotic patient?
Can it be due to
arch of aorta in Eisenmenger syndrome?
Eisenmenger syndrome, pulmonary artery can sometimes get calcified.
No.
Yes. That's why on the right side, that's why I was suspecting more, sir.
One condition, whenever you are seeing a calcification, you must look for whether it
PDA.
PDA. That's a PDA. Eisenmenger is one condition where you can get calcification. A large dilated vessels can sometimes get calcified. So pulmonary artery can get calcified. So that is possible.
The collateral calcification can be seen.
Collaterals, I do not know whether they can really get calcified. Usually, large vessels are aorta is not usually calcified. It's pulmonary artery that can get calcified, and latent rectus arteriosus, which has developed Eisenmenger reaction, get calcified.
Okay, sir. Okay, sir.
Okay, now we'll go to the echocardiogram. Okay, what do you, somebody can interpret? Karan, would you like to interpret? What do you see? First one is a?
The first one is parasternal long axis view.
Parasternal long axis view, very good.
Sir, in which sir, we can see the vessel anterior to the left atrium is very much enlarged.
Yes, very large vessel is seen.
Yes, sir. And the sir, mitral valve, sir, normal. And sir, that the valve of that great artery is little buckling type is there, sir. Little thick, but so not fully prolapsed, but sir, little thick is there, but sir, we cannot see the, any bifurcation of that vessel.
You cannot, you would like to see the bifurcation because in this cyanotic congenital heart disease patient, where our diagnosis transmission of great arteries, the vessel which is arising from the left ventricle should be?
Should have a bifurcation, sir.
Yeah, it should be pulmonary artery.
Yes, sir.
And pulmonary artery can be diagnosed by can be identified by finding whether the vessel
Bifurcation.
Bifurcation.
Okay, so we are discussing more. At the moment, we are not seeing any bifurcation, and this is a large vessel. And so, till we see the bifurcation, we should keep a possibility of aorta, whether it's aorta or no. Okay, right. Let's go ahead. What is the next one? So,
sir, parasternal short axis view.
Excuse me, sir, but VSD can see, sir. VSD, can we comment on parasternal long VSD? Is there?
There is a VSD, but it is not very clear. So I thought you can make. There is
no, it is clear.
There is a VSD here. There is a VSD here.
Yes, VSD is there.
What type of VSD is there? Is it a subaortic VSD or what is it?
Sir, vessel we are not very sure, but
Short axis we can.
No, looking at the VSD, what do you think? It's a subaortic VSD or you think that it is
no, sir, perimembranous.
Perimembranous is a subaortic VSD.
subaortic.
Short axis we can see.
No, even in long axis, there is a tissue between the aorta and the.
The muscular looks like.
It's a muscular VSD because then the tissue between the there is some tissue is seen between the vessel and the vessel what you are seeing there and the VSD. So it must be a muscular VSD. So it looks like a muscular VSD. Okay, now coming to the next one.
So next one, sir, right up, sir. Sir, the sauces and circle, sir, that in that view, sir, I can see the circle of the great artery in the center, but sir, the artery which is which should have make a sauces, sir, that is not properly seen.
Can you see a valve here? There are
yes, sir, two valves are seen properly, and most probably, sir, both looks like a circle.
And do you think that these valves are anteroposterior or they are?
Yes, sir. They are anteroposterior. They are, sir. Normally, aorta is posterior and to the right, which is, sir, here they are looking anteroposterior. There is no right and left disposition.
So the vessels look more like anteroposterior relationship, and still you are not able to identify which is the vessel, which is aorta.
No, sir. In the third diagram, sir, we can identify little down. Both the great arteries are side by side. The larger artery seems to be bifurcated, which is on the left side, whereas on the right side, another artery is seen, which is smaller in diameter, and possibly that one is aorta, and the larger one is maybe, sir, pulmonary artery, because it's most probably, sir, bifurcated.
You mean this you are commenting about this image?
Yes, sir. Third image. Yes, sir. Yes, sir.
Third image.
Lower down.
So your comment is that you are seeing a
two arteries are seen side by side. The larger artery.
This the two arteries. The one is this and this one.
And sir, one is on the left side of this one, sir. Yes, sir. This one. Yes, sir.
Oh, I don't think I can identify it as a vessel because I got great difficulty because I am not able to see a valve, its continuity. So I will restore my comment. I will say that the one vessel is seen. It seems that I agree with you that this vessel is actually bifurcating. Because if you are very careful, you can see two vessels here. It is bifurcating. So in that case, this could be
pulmonary artery.
So we'll have to go further and see what is happening. And what about this echo? No more information. We'll go to the next one. Okay, let's see. What do you find here?
Sir, ASD is seen.
Yes, there's a large AST seen. This is probably man-made. That's a large one. And what is the direction of AST flow?
Mainly left to right.
It's
Left to right.
mainly left to right, but there is some blue color also is coming. So there is a bidirectional shock. There is some blue, but mostly it is a left to right shock. It is coming from the left atrium to the right atrium. So it is mostly a left to right shock. Okay, right, yes. And here also you can see more the left to right shunt. You can see the VSD here. There is a tissue between the VSD and the
muscular VSD.
So it is a muscular VSD. Okay, right, yes. This is a frozen image. You can see that this great vessel is bifurcating. You can easily see. So this is a pulmonary artery. And you can also see the large AST. Okay, this is showing the AST flow. You can see mostly the flow is from left to right. But there's some blue color also is coming towards the late phase. So indicating that there may be bidirectional shunt across the atrial septal defect. Okay, interpretation of this image.
So here the vein which is draining into the right atria is showing some turbulence. So normally this is a site for the SVC.
Yeah, I think it's a site for SVC. So unless otherwise, unless there is some other features for you to suspect that it is not SVC, I think you should go with SVC. AST, can you see a right to left flow?
Yes, sir.
Yeah, I think there is a right to left flow also. Mostly it is left to right, but there is some degree of right to left flow also. Okay, right, yes. Can you hear? You can again clearly see that there is a.
Mainly towards the roof, sir. Right to flow, right to left.
Mostly it is a right to left flow. Sorry, mostly it is a left to right flow, but terminal you can see some degree of blue color indicating that there is some. It's a bidirectional flow. Okay. Any other information?
Sir, here pulmonary veins are engorged. Two pulmonary veins are visible.
Yes.
Sir, one seems left and another is right. Two are seen, sir. Difficult to say, but they are, sir, dilated.
Yeah, they are dilated, but they are draining normally to the
left atrium.
Left atrium. Okay, right. They are draining normally to the left atrium. Yes. What does this show?
Yes, sir. Sir,
what is this valve? What is this valve?
Sir, that one is the pulmonary valve most probably because sir, that enlarged.
We have identified this vessel as a large vessel as the pulmonary artery. It's a pulmonary valve, and we have also found that this vessel is bifurcating. And what is this valve?
Mitral.
Mitral valve. So this is the mitral valve. This is the left ventricle. So the pulmonary artery is getting connected to the
left ventricle.
Left ventricle. And there is a muscular VSD. You can see the muscular VSD. And what is the direction of the blood flow in the VSD?
So left to right, predominant.
Yeah, predominantly left to right flow. You can see that.
Two jet is seen, sir.
Yeah, mostly it is a predominantly it is a left to right flow, but there is some degree, maybe some degree of bidirectional also is there, but mostly it is left to right flow.
Better we can say restrictive VSD?
Yes, it is restrictive VSD because VSD is very small. It is not a VSD which can definitely it's a restrictive VSD. It's not a large VSD.
And sir, one question, sir, that ASD without any history, we can say it is man-made, or with history only we have to collaborate?
Only history. From this picture, I cannot make
Yes, sir. Yes.
make any comment at all, because it can go with any already existing congenital ASD also. So there's a history that the patient has undergone two subthostomy procedures. We can say that there must have been an ASD which has been actually enlarged by the procedure. Okay, anything else? Yes, any other comments?
Now VSD is very well seen in the last two.
Yes, there is a gap, and then VSD is seen. And what is the direction of VSD flow? Mostly from the left to the right. Left to right. It's mostly a left to right flow. You can see here also. It's mostly a left to right flow. And the large vessel is seen, which actually we have identified as the pulmonary artery. Okay, so what is the final? Okay.
The pressure gradient across VSD we have not taken. Pressure gradient across the VSD.
No, we are not taken that. If there was a pressure gradient, we would have actually we could have measured the pulmonary artery pressure. How can you measure the pulmonary artery pressure? By looking at the VSD flow?
Sir, now, sir, left lower picture, sir, we can see most probably two great arteries.
Yeah, very good. You can see two great arteries.
Sir,
now, one is here and other is here. You
another
can see
on the right. Yes.
Yeah. Two great arteries are seen. Very good. You can one large vessel which is posterior, and the other vessel which is most likely anterior, which is maybe the aorta. This must be the pulmonary artery. You can see here also. Everywhere you can see two vessels very well seen. Here you can see that a restrictive VSD is there. It is most likely a muscular VSD. You can see the mitral valve. So all put together, it's a very complex situation. So all put together, what is the diagnosis? What is our final diagnosis? Arun, would you like to tell the final diagnosis?
Cyanotic congenital heart disease.
Cyanotic congenital heart disease.
Cytosolitis.
Cytosolitis.
Levocardia.
Levocardia. So you should mention about the solitis and where the heart is in your diagnosis. Yes. Detransposition of
great arteries.
Yes.
With the AST, probably post-procedural AST.
Yes. Yes.
With the muscular VST, restrictive VST, left to right shunt.
Okay.
And
we have not measured the pressures, but looking at the vessel and all, it seems that the pulmonary artery pressure is very high. So it's severe pulmonary artery hypertension. The Eisenmenger reaction. Pulmonary regurgitation mild. We had some degree of pulmonary regurgitation also seen. No evidence of heart failure as present. Previous balloon septostomy. So that will be the full diagnosis. So any investigations you would like to do, and why do you want to do those investigations, and what are the management strategy in this patient? To decide the treatment, any investigation that you would like to do? Would you like to do a cardiac catheterization?
Yes, sir.
Yeah, why?
Sir, because sir, now sir, we have two options. Like sir, because here sir, left ventricle is facing to the lower pressure pulmonary circulation, and if we want to change it the arterial switch, then sir, we have to see whether this ventricle will be able to take the pressure of the aorta.
Okay.
So, sir, to know the this, sir, we have to do the cath study, and also, sir, we have to see how much pulmonary arterial hypertension has developed, because the boy is, sir, so 22-year-old, and sir, Eisenmenger has developed.
Yeah,
So
there is evidence that from the clinical findings and other things, it seems that patient has already developed significant pulmonary artery hypertension, Eisenmenger syndrome.
but still, sir, we should once search that whether any reversibility is present or not.
Yeah. How will you go to the, how will you record the pressure in the pulmonary artery in this patient?
Sir, here, sir, it is in the pulmonary artery, sir.
Oh.
Sir, we will go through the femoral arteries. So pulmonary artery is.
How will you reach the pulmonary artery?
Via VST, you can do VST is there.
So from the ASD, sir, we will go.
Yeah,
So
only which you can reach is that through the ASD you should
Yes,
get
sir.
into the LV, and from there LV you have to enter the.
Yes, sir. The pulmonary artery.
That is the only process by which you can enter the pulmonary artery. Through the ASD into the LV, then into the pulmonary artery. Otherwise, if you go from the aorta, you will reach the femoral artery. You will reach the right ventricle. And if you go through the femoral vein, where will you reach?
Femoral vein, right atrium, right ventricle, and aorta.
Yes. So that is the problem in this patient. It's difficult to get into the pulmonary artery. So if you want to get into pulmonary artery, you have to cross through the ASD, get into the LV, and then from there you can get into the pulmonary artery. So since the patient is 22 years old, then all put together, we had a feeling that the patient is having a large pulmonary artery. Patient is having pulmonary artery. Most likely there must be pulmonary artery hypertension. So we thought that there is no point in further evaluating the patient, and we thought of palliative treatment. What are the palliations possible in this patient? Most important is that you have to look at the hemoglobin. If the hemoglobin is more than 20 grams, these patients will benefit by venesection. You can do venesection associated with infusion of
normal saline.
Normal saline can sometimes give a relief, because of the when there is a hemoglobin is more than 20 grams, that can give rise to almost hemoconcentration, and that will result in slow circulation. It can give rise to headache. It can rise to venous cortical anomalies, or the flow can be slower. All those problems can happen, and so these patients with severe hemoglobin is more than equal to or more than 20 grams will require venesection, and with that the patients usually get a good relief. So here only palliation is possible. I don't think we can do anything more. So we'll just discuss about some of the surgical treatment possible in patients with cyanotic congenital heart disease. We'll go to that. Let me see whether we can discuss some of the surgical options. So in congenital heart disease, what are the surgical procedures that can sometimes give relief to the patient? Can you mention 4 surgical procedures? Okay. How will you? Sometimes you would like to increase the pulmonary blood flow. How can you increase the pulmonary blood flow?
So shunt procedures.
Shunt procedures. You can give systemic to pulmonary artery shunt, BT shunt, vortex shunt, short shunt, central shunts. Nowadays it is not being done. And what are the conditions in which you give a shunt to the pulmonary artery?
Sir, what is the indication for shunt to the pulmonary artery?
Yes.
Sir, the conditions with the decreased pulmonary flow, like pulmonary atresia, severe pulmonary stenosis.
of physiology.
But nowadays we mostly going for total correction. As even at the young children, 6 months of age, they try to do correction. So what are the conditions where you think that even before giving total correction, you may have to do a shunt procedure? Intertrolial fellow, when will you think of doing a shunt procedure?
When pulmonary arteries are hypoplastic.
Yes, one is very good. When the pulmonary arteries are hypoplastic, where you think that pulmonary arteries have to develop, and then only we can do a real total correction. Then you have to do a shunt to improve the to develop the pulmonary arteries. Yes. What will be? How will you assess the size of the pulmonary artery? How will you assess the size of the pulmonary?
So to Nakata index.
Ah.
That is from the, sir, we have to do with the CT scan. Sir, we have to take the diameter of the aorta at the descending aorta at the diaphragm level, and also the LP and the RPA, sir.
Okay.
The ratio we have to take, sir.
Oh. What is the ratio?
Sir, it should be at least 0.7.
0.75. Okay, 0.7. At least 0.75. The ratio between the aorta to pulmonary artery should be 0.7. Pulmonary artery to aorta should be 0.75. Okay, right. Yeah. So usually that is the measurement that we usually take the aorta in the descending thoracic aorta to the pulmonary artery size. Okay. So one indication is that when the patient is having the pulmonary arteries are hypoplastic, and in order to help the development of the pulmonary artery, you can give a shunt. Okay. Second indication.
Sir, if the collaterals are very small and baby is still not fit for the full intracardiac repair.
Very good. The baby is so sick that when the collateral flow is so inadequate that if you go for a intracardiac procedure, the surgical risk is very high. Then you would give a shunt pulmonary artery, develop the pulmonary artery, and then subsequently do a total corrective procedure. Okay. Third indication.
Presence of branch pulmonary artery stenosis.
Branch pulmonary artery stenosis, nowadays you can do stenting and all. You don't have to give a shunt because you can do stenting after the corrective procedure. If it is not corrected by the surgeon, you can think of doing a stenting. Another indication is that the patient is so sick that the patient is getting recurrent episodes of cyanotic spells, and where you think that the regular treatment is not effective, patient is deteriorating, and then sometimes shunt to the pulmonary artery can solve the problem. And once the child has settled down, then you can think of doing a intracardiac repair. So these are the few situations where you nowadays you would like to do systemic to pulmonary artery shunting. As far as possible now, most of the times the total intracardiac repair is favored, and these patients can undergo the procedure as low as young as 6 months of age. So nowadays, most of the institutions where the congenital heart disease surgery is being carried out, they recommend total correction, intracardiac repair of the tetralogy of Fallot. There are some situations where you like to keep the duct patent by doing prostaglandin infusion or duct stenting, especially the duct dependent pulmonary circulation, where prostaglandin infusion or duct stenting can be done. Can you tell me one or two examples? Duct dependent pulmonary circulation.
Pulmonary atresia with intact vertical septum.
Very good. Pulmonary atresia. Very good. What else?
Hypoplastic left heart syndromes.
Yes.
Aortic
yeah. There are a few situations where, and also in pulmonary atresia, of course, and in some of the patients with where the keeping the duct open may be very important, and there it can be kept open by prostaglandin infusion or by duct stenting. Sometimes you may like to decrease the pulmonary blood flow by doing pulmonary artery banding, or you may do pulmonary artery banding in order to increase the pulmonary RV load, LV load in a patient with transposed to greater arteries, so that the regression or the evolution of the left ventricle does not take place. Okay, now let's look at Fondant procedure. Fondant procedure is something you should know very well. What is the indication for Fondant procedure?
Fondant procedure indication is that when intracardiac repair, two ventricle not possible, sir.
Yes. In patients with single ventricle physiology, or in patients with two ventricle physiology, where the repair is not possible with two ventricle physiology, then sometimes you may resort to a single ventricle physiology. So usual conditions where single ventricle physiology is there, and you are doing a Fondant procedure or tricuspid atresia, hypoplastic RV with pulmonary valve atresia, and intact interventricular septum, mitral atresia with mitral atresia, hypoplastic left heart syndrome, single ventricle, DORV with non-committed VSD. These are few situations where Fondant procedure is being recommended, out of which most important is tricuspid atresia, and in patients with single ventricle, sometimes Fondant procedure can definitely be useful. For the Fondant procedure to be effective and the patient to live long, the ventricle which is functioning should be left ventricle. If it is the functioning ventricle is right ventricle, the Fondant procedure patient can develop complications after about 4 to 5 years, and the survival is restricted. So only if the Fondant procedure patient should have to live long, this patient should have the LV as the single ventricle. And what do you do? How do you select patients for Fondant procedure? Suitability?
Suitability, sir, we have to see that left ventricle failure should not be present. So there should not be very significant aortic valve regurgitation.
Okay, very good. There will be good LV and valve regurgitation. Valve should be functioning normally. Both atrioventricular valve and semilunar valve must be functioning normally. Okay, yes.
And sir, the pulmonary arterial pressure is sir, transpulmonary pressure should be present, sir. We want sir, pulmonary artery to the towards the left atria, the blood should flow, so that left ventricular end diastolic pressure or the left atrial pressure or pulmonary capillary wedge pressure should not be very high.
Yes. So you can say that the pulmonary artery mean pressure should be less than 15 millimeters of mercury. That will be easiest to say. The mean pulmonary artery pressure should be less than 15 millimeters of mercury. So that will indirectly reflect that the pressure drop across the pulmonary vasculature will be normal. Okay, right? Yes.
And so venous drainage should be
the systemic venous drainage.
Yes,
systemic venous should be as far as possible normal. Yes. What else? Normally functioning left atrioventricular valves. Pulmonary vascular resistance should be less than resistance index should be less than 2 Wood units, or if you look at the pulmonary vascular resistance, it should be less than 4 Wood units. But pulmonary vascular resistance index should be less than 2 Wood units. So there are few requisites before we think of Fondant procedure. It is a single ventricular physiology. Good pulmonary arteries, PA to aorta size should be more than 0.75. Mean pulmonary artery pressure should be less than 15 millimeters of mercury. Pulmonary vascular resistance index should be less than 2 Wood units. Pulmonary vascular resistance can be up to 4 Wood units. Normally functioning left atrioventricular valve as well as semilunar valves. Good left ventricle. And age, usually the age in which we do Fondant procedure is, what is the age in which a Fondant procedure is recommended and best done? Around 4 years of age. It's usually around 4 years of age. It can be done up to 15 years, but 4 years of age would be the most ideal time when the patient can undergo a Fondant procedure. And what do you do in Fondant procedure? What is the initial Fondant procedure and now how it is being done? Any one of you? What was the initial Fondant procedure? Fondant does not have an E here.
There are two fontans. One is semi-fontan, another is total fontan. So in case of semi-fontan, we usually do that SVC blood will bypass the right atrium and it will be connected to the pulmonary artery. And after some time, so that the pulmonary artery is not flooded, and the single ventricle will be little less overloaded from the systemic circulation. As a result, the blood from the upper part of the body, it will be diverted directly bypassing the single ventricle. Okay. Now, sir, after some time, sir, we will do the completion of the Fondant procedure. This completion is in which, sir, we will now, sir, IVC will be also connected to the pulmonary circulation, either bypassing the right atrium or, sir, taking the right atrium with it. So that can be of two types. So that can be, sir, within the right atrium, or, sir, we can make a tunnel in the right atrium, and sometimes, sir, we can make a fenestration also. And like that,
fenestration where?
Sir, fenestration between the right atrium and the tunnel which we are making, so that sir, if the pressure in the left side of the heart increases, then it will, sir, not cause the it will take the pressure, that pressure.
Okay, so that is actually an outlet. If the pulmonary artery pressure goes up due to any reason, that will be an outlet. Okay, so but what is the original Fondant procedure? You are right now. What you are?
It was semi-fontan only, most probably, sir.
And
sir, in original, sir, pulmonary artery was cut. Sir, pulmonary artery was dissected and separated totally.
Originally, they did only in tricuspid. First was done in tricuspid atresia patients, sir. And they used two valves also for connecting the vessels to the pulmonary artery, sir. They used
they actually made use of a valve in between in its connection.
Yes, sir. Two valves they were used before, sir. Now that they are not using the valves.
So the original communication was from
the RVC to CA.
Right atrial appendage to the left pulmonary artery. Sometimes maybe through a conduit or maybe directly, and SVC to RP. That was the first Fondant procedure, where the right atrial appendage is connected to the left pulmonary artery through a conduit, and SVC is connected to right pulmonary artery. The systemic venous return system is channeled to pulmonary artery bypassing the right ventricle. So what are the problems with the original procedure? The problems were that you have to cut open the right atrium. That has resulted in arrhythmias. Especially associated. They can have even sick sinus syndrome and all those things. So it was went out of repute. Then they came the modified Fondant procedure. And modified Fondant procedure is there are many modifications. It can be done as a staged procedure also, but the most important modification is that intra-atrial tunnel from IVC to SVC. Then the systemic venous return can be connected to pulmonary artery outside the heart by direct KO pulmonary communication. So the procedure is done outside the heart, where the superior vena cava is connected to the right pulmonary artery, and inferior vena cava also can be connected both are connected end to side to the pulmonary artery. So there can be a normal, both the IVC as well as SVC can drain into the pulmonary arterial system, and you can always leave a vent, so that if there is an increase in the pressure in the pulmonary arterial system, that there can be an outlet from the IVC into the right atrium. the procedure in which the modified Fondant eliminates the risk of pulmonary venous obstruction. Many times when you are doing the Fondant procedure, it was observed that there can be sometimes damage to pulmonary veins, pulmonary venous obstruction. It can be compressed upon, and that can result in the pulmonary venous pressure going up. That will result in pulmonary arterial pressure going up, and that will result in systemic venous congestion. So the Fondant procedure was associated with a few complications, and with the modified Fondant procedure, the complications are much less. What is the Glenn procedure?
Sir, it is semi-Fondant, sir.
What is it?
In this, sir, we are connecting the superior vena cava to the
Right pulmonary
right. Sir, this can be right pulmonary artery, sir.
Yes. The Glenn procedure is one in which the SVC is connected to right pulmonary artery. What is bidirectional Glenn?
Sir, in bidirectional, we will connect it, and sir, we will cut the main pulmonary artery so that the blood from SVC to RPA to MPA to LPA.
Yeah, what did you say?
Blood from, sir, blood from sir, there is a sir, blood from the superior vena cava to the right pulmonary artery.
Very good.
Then, sir, MPA is there, main pulmonary artery, little part. Sir, from there is a connection of, sir, left pulmonary artery is also coming there. So in the main,
where will you connect IVC?
SVC.
IVC. SVC is connected to right pulmonary artery.
Yes, sir.
Where will you connect the IVC?
MPA.
IVC can be connected through a, sometimes people even do a, it is taken outside the right atrium and can be connected through a conduit into the near about the junction of right pulmonary artery to the MP. So that there can be bidirectional Glenn where the blood can flow. From the SVC, it can flow mainly to the right pulmonary artery, and from the IVC, it can flow mainly to the left pulmonary artery. So there can be, but these things are enough for you. But Glenn procedure is SVC to pulmonary artery, SVC to pulmonary artery. Original Fondant procedure is that you are connecting the right atrial appendage to the left pulmonary artery and SVC to the right pulmonary artery. And this has got the disadvantage that patient can develop major atrial arrhythmias and also sick sinus syndrome. And this was replaced by SVC to the right pulmonary artery, and IVC. It can be formed into a tunnel, into an intra-atrial tunnel, and it can also get connected to the right pulmonary artery, both in an end-to-side anastomosis. And that is so. Depending upon the expertise of the surgeon, any form of modified Fondant procedure can be carried out, and that is the treatment option for single ventricle, or ventricle where only one ventricle can be functional. And what are the complications of Fondant procedure? What are the complications of Fondant procedure? Immediately after the procedure, sometimes these patients can develop pleural and peripheral diffusion. They can have atrial arrhythmias, sinus node dysfunction, and so if there is a
protein losing enteropathy.
Protein losing enteropathy.
Sir, there is a failure, sir, of the left ventricle.
Yeah, if the left ventricle fails, then that will give rise to all types of complications, especially
edema, ascites.
Pulmonary pressure can go, and usually it is not a very. What is the usual life expectancy of patients who undergo Fondant procedure? How many? What is the, if everything is ideal? What is the survival? 10-year survival.
10 years.
10-year survival. What percentage of patients can survive up to 10 years?
50%, sir.
Yeah, about around 75% can actually, in all ideal conditions where it's done by in a good center, then the survival can be up to 75% at the end of 10 years. Okay, what are the other surgical procedures? What are the problems of tetralogy of fallot repair? At what age do you do tetralogy of fallot repair? Endocardiac repair? What is the age in which you do tetralogy of endocardiac repair? What are the problems? And how will you overcome these problems? Usually the age is 6 months of age. That is the age in which usually endocardiac repair can be carried out for tetralogy. What are the problems that you face in endocardiac repair?
Whether we have taken the conduit or not.
Yeah. Yes.
And the approach is important. Whether we are going through the RA approach, right atrial approach, or outflow approach. So in case of if we are using conduit and right ventricular approach, there is a more chance of pulmonary regurgitation, sir.
All patients, when there is a remodeling of the RV outflow with the use of a conduit, can result in pulmonary regurgitation. That's one of the main problems. Usually, the pulmonary regurgitation previously was thought that it is insignificant, but we now know that pulmonary regurgitation patients can gradually develop RV failure. That is because the regurgitation is taking place to an hypertrophied RV, and that can be sometimes give rise to problems. Okay, right? Yes, pulmonary regurgitation. In the patient is having pulmonary regurgitation, how will you manage?
Sir, in case of TOF, sir, surgery is, sir, we are gaining the at the cost of sir pulmonary regurgitation. So, sir, mild to moderate pulmonary regurgitation we may accept, sir.
Yeah. Mild to moderate or low moderate is acceptable, but now we know that more than moderate pulmonary regurgitation.
Then the pulmonary valve replacement is possible nowadays.
You have to replace the pulmonary valve. And
bioprosthetic valve.
That is being recommended. Bioprosthetic pulmonary valve replacement is being recommended, and these patients improve significantly. Following an intracardiac repair, what should be the pressure relationship between the right pulmonary from the pulmonary artery and the left ventricle? For you to say that there is a successful procedure.
The left ventricular end diastolic pressure should be less than.
No. Left ventricle, not in left ventricle end diastolic pressure. RV systolic pressure.
Less than 6.
Less than 6. What should be the RV systolic pressure in relation to LV systolic pressure for you to say that you have done a good intracardiac repair? Any one of you? It should be less than 2/3 the LV systolic pressure. Only when it has fallen below 2/3, then only you can say that you have done a good job. One of the problems these patients can have, sometimes they can have the LAD crossing the RV outflow. When the LAD is crossing the RV outflow, what is the significance and how will you tackle it?
So we will damage the LAD and the patient can have MI.
Yeah. So if you cut open the RV outflow, it may injure the LAD and the patient can go in for an anterior myocardial infarction. So how will you manage that situation?
So we have to go through the right atrial approach or something like that.
And you can open up the pulmonary artery. And in case if it is very important that you have to give a conduit to the pulmonary annulus, then probably you may have to sometimes you may have to give a conduit from the RV outflow to the pulmonary artery, where it is impossible for you to repair the RV outflow. Sometimes you have to give a conduit. Otherwise, as you rightly said, you can have a right atrial approach, and the cutting open the RV outflow can be minimized, and that can result in good relief to the. But this information should be available before the surgeon goes to the procedure. and it should be totally planned before the surgical correction is attempted. Then transposition great arteries, arterial switch surgery, atrial switch surgery. Nowadays, atrial switch surgery is not done, only arterial switch surgery is done. What is the age in which arterial switch surgery is done, and what are the problems of arterial switch surgery?
It should be done in 1 month.
Yeah, as early as possible. Very often it is being done before the 1 month of age because we don't want the LV to regress. Right, okay. What are the problems of arterial switch surgery?
Mainly, sir, coronary arteries, sir, we have to transplant also.
Mobilize and reimplant the coronary arteries to the newly formed aorta.
Yes, new aorta.
New aorta. So that is the one problem that can happen. And second is that over a period of time, these patients can develop aortic regurgitation. That is because the aortic valve is the original pulmonary valve, and the pulmonary valve cannot support systemic circulation. So these patients can develop aortic regurgitation. But as a whole, this is a very good surgical procedure. Everything else is corrected, excepting the coronary arteries are to be reimplanted, and also the valve which is supporting the systemic circulation is pulmonary valve, and these patients can develop aortic regurgitation or pulmonary regurgitation, whatever it is. What is the Rastelli procedure?
Sir, Rastelli procedure is, sir, one last part of the sir, this arterial switch operation, in which, sir, what we are doing, sir, we are closing the VSD, and sir, we are making in such a way so that the sir, RV and pulmonary artery are communicating, but sir, there will be a gap between the left ventricle and the aorta. Then, sir, we will give a conduit.
Yeah. Actually, the conduit is given from the left ventricle through the VSD into the aorta. So that is the Rastelli procedure, where conduit is given from left ventricle to the aorta. So these are the few surgical procedures which the examiner can ask. So you must know about the intracardiac repair of the Trolley fire. That's very extremely important. You should know everything about Fondant procedure, selection of patient, suitability, and what are the conditions you can do Fondant procedure. You must know about the Trolley fire intracardiac repair and what are the problems of intracardiac repair. You should know about transposition of great arteries, its arterial switch surgeries problems, and in DRV, what are the surgical procedures possible. And what is the surgical procedure that we do for hypoplastic left heart syndrome?
Fondant only, sir.
Good procedure.
Fondant is possible, but there is a multi-stage procedure.
Yes, sir. Name is, sir, it starts from N.
Yeah, right.
Sir, very 3-stage operation we have to do, sir.
Norwood procedure.
Norwood procedures.
You must read about that. There can be stage procedure. Well, how long these patients will survive, that's a different question. But in the examination, you may be asked about the stage procedure for hypoplastic left heart syndrome. Okay, I think it's all about the congenital cyanotic heart disease surgical procedures. You must have an overall idea. Most important thing is that you must know very well about intracardiac repair of the Trolley fellow. You must know very well about the arterial switch surgery for transposition of great arteries and Fondant procedure for single ventricle. So once these 3 things are known, I think that's enough.
Sir, one question that in VSD to calculate PA pressure, sir, we have to know the blood pressure also, no, sir. They will reduce and then we'll get the PA pressure.
Yeah. You will have to reduce the from looking at the gradient across the VSD, that should be reduced from the systemic systolic pressure. That will give you the right ventricular pressure. Okay. Any other doubts? If there are no doubts, so we'll stop today we'll stop the discussion. And next class, what do you want? Should we go for another case discussion, or you would like to have some spot lists? Let me see whether I can show you some spotters for half an hour.
Thank you, sir.
Okay, right. I think we'll have the further discussion next class. Would somebody would like to bring a case tomorrow next class? Eknath, would you like to bring a case?
Yes, sir. I will bring case.
Eh?
I will bring case, sir.
Okay, so you bring a case from the next class. We'll have a discussion about that case, and that will be more lively. Okay, and after the next class, we will have some spotters, especially echo spotters. We'll have some pressure tracing spotters, angiograms. So that will make it a spotter session, because nowadays the spotters are also being considered as a very important method of evaluation. So you should have enough spotters, and you should be able to interpret the spotters. So we'll have spotters also. Okay. So next class, Eknath will bring a case, and we'll have a discussion on that. Okay. Any doubts about the discussion that we had? So one important thing I want to stress upon is that all of you should know about few surgical procedures in cyanotic congenital heart disease. They are: one, total repair of tetralogy of fellow. When to do, and what are the problems that can be, and how to overcome those problems. Two, Fondant procedure, which is what are the indications for Fondant procedure in cyanotic congenital heart disease, and how to select the patients, what are the problems, and how to follow up, what are the complications that can happen, and all those things about Fondant procedure that should be known to you. Then switch surgery for transverse arteries, artery switch surgery. And finally, somebody may ask you about a Rastelli procedure also, but may not be. These three are the most important: Fondant procedure, total intracardiac repair for tetralogy of fellow, and also what will you do for transverse arteries. And those patients who have got double outed right ventricle, sometimes you may do a Rastelli procedure, which is a conduit from the left ventricle through the VSD into the aorta. Okay, I think we'll stop at that level. Okay.
Thank you, sir. So can I end the meeting with your permission?
Okay, right. Yes.
Okay, so I'm ending this meeting now. Thank you.
Okay, right.